So now we're going to move on into neuro issues, neurologic issues. So with neurologic issues, you know, the tendency is going to move towards having a really good in-depth knowledge and breadth of stroke and seizures. But don't forget things like headache and other neuromuscular disorders. And that's kind of my point on bringing some of this stuff up here, is just because I know that you've been learning about stroke, hemorrhagic stroke, occlusive stroke since you started EMT school, and seizures and things like that. And we'll get into some of that particular stuff, but don't discount that somebody's just got a headache or something like that, because it could be an indication of something much more sinister. With your specific neuro disorder, so your stroke, your occlusive stroke, and your hemorrhagic stroke, one of the things that's kind of textbook that you need to know is the ability to know the difference between a stroke and a occlusive stroke based on signs and symptoms. With the most textbook sign of hemorrhagic stroke being what? The worst headache they've ever had. So your occlusive stroke, you know, it's going to occur when there's some kind of blockage of a cerebral artery. Clot, foreign matter, embolism, and the mechanism there is essentially the same as a MI or a coronary clot. You start becoming ischemic, and then you go to necrosis or infarction. Now, the brain is a very complex organ that has very, very many functions. Particular signs and symptoms may not always give you an exact view of what's going on, meaning that depending on what area of the brain has been affected, you may have different results. The thing that matters is for us in the field when it comes to occlusive stroke or embolic stroke is going to be doing that thrombolytic checklist. Now, of course, we're not going to be able to tell if it's a thrombosis or if it's some other type of embolism, but we can go ahead and do that checklist and get that baseline information, because we know that time is brain, right? And if they can do thrombolytics, then that may in turn really help that patient out. Hemorrhagic strokes are going to be categorized as being within the brain or around the outer surface of the brain. So you have your inner cerebral stroke, you're bleeding inside the brain, and then you've got your subarachnoid. So of course your big things with your stroke we're looking for are signs of our Cincinnati pre-hospital stroke scale, right? Facial droop, arm drift, slurred speech, things like that. It's very important when you suspect issues to do a neuro exam. A patient with stroke may not always just give you absolute signs and symptoms. Listen to them. See what's going on. When was the last time they were seen normal, right? Now, if they went to bed normal and they wake up stroking, then we have to go with, well, they went to bed normal, because we don't know at what point during that time it may have occurred. Now, they generally say 4 to 6 hours after the onset of symptoms, they will start doing thrombolytics. Now, that's up to the doctor, though. We still will do that thrombolytic checklist no matter what. Now, also remember that systems like EMS systems are a very huge part of care. And we have in Alabama a stroke system. And essentially the stroke system is to understand that patient needs care quickly. Time is brain. And so putting them into that stroke system may really eliminate the middleman there and get them to the care that they need. And of course, always, you know, questions when it comes to this kind of stuff is, you know, if it's a transport question, you've got to get them to the appropriate facility. I would know the difference in the Los Angeles pre-hospital stroke screen and the Cincinnati pre-hospital stroke screen. So the Cincinnati pre-hospital stroke screen, it essentially covers facial droop. What else? Facial droop, arm drift or extremity, and what? Speech. With the Los Angeles pre-hospital stroke screen, honestly, you pretty much do all the components of the LAPSS when in your assessment, because it covers the three things with the Cincinnati Pre-Hospital Stroke Scale, but it also covers things like, are they a bed-bound patient? What is their blood sugar? Are they running fever? Things like that. So TIA, the definition of TIA is going to be a patient with stroke-like symptoms that resolve usually within 24 hours. It's very important that you as a provider know that if they had stroke-like symptoms and they're not having stroke-like symptoms now, that the body doesn't just normally just go around saying, hey, I'm going to decide to have a stroke. Hey, oh, I'm better now, just for funsies, right? It's a precursor. There's something going on, and they need to be checked out. Obviously, your care for your stroke patient, and even TIA patient, is going to be rapid transport, get them to the appropriate facility quickly. But there's also that psychological aspect as well. Now, there's so much more that goes into the stroke that you guys need to read over, but one of the big issues here is that, hey, I've got these symptoms that's affecting my thought process. I've got these symptoms that are affecting my speech and my communication process, and I can't figure out why this is happening. And in some situations, you've got a patient that may have something like expressive aphasia, meaning that they can process what's being said, right? But they can't get out what they want to say. So somewhere between the brain and the mouth, that message that their brain had encoded and then now is trying to send out has been disrupted. And so in that situation there, it becomes very scary and very frustrating for that patient. And then it's also frustrating for you as the provider, because you want to help your patient, but you can't figure out how. With your stroke patient, just because they may have difficulty communicating or just because they may have difficulty expressing themselves to you, does not mean that they are cognitively impaired, and you need to remember that. I mentioned systems with stroke. One of the things that you need to know is the fast mnemonic. Do y'all know the fast mnemonic?
Facial droop.
Yep.
Arms, speech, time.
Time, yep. Now, a little history on the fast mnemonic. So the fast mnemonic was actually created as a way to educate the public on stroke. But what we've done as EMS professionals is we've adapted that and actually created a scoring system off of that. And that time for the public, the T in time is going to be time is essential. Let's get them to the hospital. But for us, the T in time is going to be time since last seen normal. Seizures. With your seizures, understanding your difference in your generalized and your partial seizures. Your generalized seizures are the seizures that we're going to most often treat, your grand mal or your tonic clonic. I guess the appropriate term for the grand mal is tonic clonic, where you have your tonic phase and your clonic phase. One of the ways that I remember tonic clonic phases, the tonic phase, that's going to be where you've got that rigidity, that increased muscle tone, tonic, increased tone, whereas the clonic phase is going to consist of your rhythmic jerking motions. Absent seizures also fall under the generalized seizures, your petit mal, where you present with a 10 to 30 second loss of consciousness or awareness. And then with your partial seizures, so the issue or the differentiation between your generalized seizures and your partial seizures. Your generalized seizures, they diffusely affect the brain, whereas your partial only going to affect one area of the body, and so you're going to only see the effects in one area of the body. This may be movement or dysfunction of an extremity, or you may see twitches in the hand or something like that. Typically, you're not going to see you're not going to see and feel partial seizures. But with generalized seizures, key here with a person that has experienced a seizure, one of the most important things that you can ask this patient is, do you, or the ones around them, do they have a history of seizures? Because a person that has a history of seizures, experiencing a seizure, is not a great thing, but a person that does not have a history of seizures and now they're experiencing a seizure, that is a bad omen. That is a bad sign. we want to make sure that that's documented and treated. Nonetheless, with seizures, your physical exam should rule out any type of trauma, blood sugar issues, things like that. Management obviously is going to be to keep that patient from being harmed. You want to make sure that you do your best to get an airway, and then if that patient is continually having prolonged convulsions, then you want to consider your anticonvulsant medications. A benzo is the preferred treatment there. Valium, Ativan, Versed, any of those would work. The thing about something like Versed is that it can be given IM if you can't get or it can be given intranasally as well if you can't get the IV. Valium is going to work longer, and again, you're not necessarily treating the seizure or the root cause of the seizure, but you're more or less treating the symptoms of the seizure. But it is very important for you to treat those symptoms because those convulsions can cause some real issues, even death for that patient. And the other thing I wanted to mention with seizures is that most oftentimes with patients that have a history of seizures, if they're experiencing seizures now, it's usually because of a alteration in their medication, or in some cases like a headache. I do want to emphasize the significance of a severe headache. Most people are not going to call because they've just got that little tension headache, or they've got that little headache that they can take a little Aleve or Tylenol. Another point that I make with this is that if you have a history of migraines, like if any of y'all have migraines, I've never had a migraine, but I had a severe tension headache one time that, you know, is probably as close as I can compare to a migraine. The last thing I want to do is call 911 and be stimulated and be on the back of an ambulance and all of that stuff, right? And so in those situations, a lot of times these patients have done all they can, and they're really kind of at their wits' end. So again, a little empathy really helps in these situations. What do you do for a headache? You treat it. You can give pain medicine if you need to. Treat it. Also, though, remember, if it's something like a migraine or a severe tension headache or something like that, in this case, if you're going to give something to help with the pain, you want to also give an antiemetic as well. Turn the lights down, provide a low stimulus environment. So one of your questions on some of your prep work was, what's the difference in delirium and dementia? Permanence. Delirium is going to be a situation where it's caused usually by some outside influence, maybe, you know, drugs or infection or something like that. Whereas dementia is going to be caused by something that is a progressive issue. The number one killers in America, Alzheimer's disease, results from death and disappearance of nerve cells in the cerebral cortex. And then literally can see comparisons. You can Google it and look at it. You can see comparisons of a patient who's had an MRI of their brain pre-Alzheimer's and then an MRI of their brain post-Alzheimer's, and you see the atrophy of the brain, and you see the degeneration of the brain tissue. It's a very sad disease, and it's a very, very scary disease. The big thing to remember with any of these patients experiencing dementia is that oftentimes they're very, very scared, and a lot of situations you'll see that actually they're living on instinct. They're living on instinct. They're living on fight or flight kind of deal. That's why they get very combative when they get into unknown situations and just very unnerving. Pick's disease, another form of dementia. Huntington's disease is actually caused by a genetic defect, chromosome 4. With Huntington's disease, you're not going to see as much of the cognitive decline, but you're going to see more of the Parkinsonian type. The shaking and things like that. Creutzfeldt-Jakob disease, from my understanding, it actually is something that is developed from an infection or some type of, there's actually a form of Creutzfeldt-Jakob disease that affects deer. Have y'all ever heard of the zombie deer disease? And basically, from the way I understand it, an amoeba or some type of parasitic infection occurs in the brain, and it causes degeneration of the deer brain and all that. Now, I know that that's a rough comparison there, but essentially you see a very quick decline in cognitive ability with Creutzfeldt-Jakob disease. Wernicke's encephalopathy, this disease process is chronic disease that affects the brain from chronic alcoholism. One of the things that plays into the Wernicke's encephalopathy is going to be the effects of the liver and the hepatic encephalopathy that occurs due to high ammonia levels and things like that. We're central nervous system neoplasms, different types of tumors that's going to affect, depending on where they're at, is it benign or is it malignant? Again, we're going to treat symptoms. Demyelinating neurologic disorders. So what does demyelinating mean? You've got this myelin sheath around your nerves. It essentially causes a insulation of the nerve and the ability to transport the communication signals or the electric conduction. It insulates that electrical conduction, so it allows it to pass from the nerves to the synapses and all of that. With demyelinating neurologic disorders, there's certain things that affect the myelin sheath, and it actually affects the ability to send the signal. Multiple sclerosis involves inflammation of certain nerve cells followed by demyelination. And then Guillain-Barré, you see this secondary to infection, and in this case, Guillain-Barré is actually an autoimmune thing. The body mistakenly attacks the peripheral nerves, which leads to inflammation, which will lead to muscle weakness and will even lead to paralysis. Now, one of the interesting things, again, about Guillain-Barré is the fact that it actually has a ascending effect, meaning that it starts at the feet, the lower extremities, and it moves up. And patients that are diagnosed with Guillain-Barré, you may see where it just affects the lower extremities and then it starts rescinding, or you may see it move all the way up to where they're completely paralyzed and they end up on a ventilator. Now, there is a high survivability rate on Guillain-Barré as well, but they will have lasting effects. Cranial nerve disorders. Don't discount the cranial nerve disorders because, as a matter of fact, let's see, on this thing here, it says Pathophysiology of Cranial Nerve Inflammation. So be sure you look over your cranial nerve disorders. Now, a couple of the main ones that we talk about are going to be Bell's palsy. And one of the reasons why we talk about Bell's palsy is because it can have some stroke mimics. It affects cranial nerve that affects the movement of the face, the facial nerve, and you can actually see facial droop. But they don't have the other signs of stroke. And oftentimes you'll see Bell's palsy in younger people as well. And then trigeminal neuralgia. Trigeminal neuralgia affects the fifth intracranial nerve, or the fifth cranial nerve, or the trigeminal nerve, and the patient is in severe, not respiratory distress, but pain distress. They say they feel like their face is on fire. Trigeminal neuralgia is extremely, extremely painful. And it's even to the point to where oftentimes analgesics will not even touch it. A lot of times they have to get into the hospital and actually get anti-inflammatory type medications and analgesics on top of that, and it still is a very, very painful type disorder. Anytime you see the term gloss, which is just on the glossopharyngeal neuralgia on the ones listed here, but gloss, hypoglossal nerve, that means gloss means tongue. Glossopharyngeal neuralgia, this is going to affect the ability to swallow, the ability to talk. Vertigo, we know, is dizziness, affects inner ear. Again, with any of these, though, you treat symptoms, and then sometimes there may not even be anything to treat, and you get them to the hospital. Dystonias. Dystonias are often secondary to medications. One of the medications that you give in the field is Haldol that can cause dystonias, or extrapyramidal effects, EPS. And so in the field, we give what with Haldol to counteract these effects?
Diphenhydramine.
Yeah, Benadryl. So we give Benadryl to help counteract that. So with dystonias, it doesn't affect the nerve tract as much as it affects the muscle, and you see like twitches, or you may see, just very repetitive movements. You may even see where they're actually more of a tonic type deal. There was a movie that had Robin Williams in it, and it had Robert De Niro in it. Robin Williams played the doctor. Robert De Niro played a patient. They were in anyways. It is Awakenings.
Mm-hmm.
Yeah. So basically, Robin Williams plays this doctor that's in a psychiatric hospital that he's working with all these patients who are dystonic. And he figured out a way, I don't remember exactly what he did, but he figured out a way to actually get these patients to come out of the dystonias, at least for a brief time.
He used L-Dopa.
What?
He used L-Dopa.
Okay. So he figured out a way to affect the dopamine levels in the brain, and he was able to get them to come out of that.
Wasn't it moments of lucidity, and like they were like super intelligent, and all of a sudden they just go back into like almost coma state or something like that?
Right, yeah. He actually got several of them and it was like not just moments for days, and he thought that he had them cured, and then one day he came back in and they were back to their state. Anyways, a lot of times you may see dystonia patients that are psychiatric patients. Psychiatric meds can affect patients in a great way. Neurologic infections, encephalitis, and meningitis. Encephalitis can be seen because of alcoholism, more of inflammation type stuff there, but meningitis, know that there's bacterial and viral meningitis, and viral meningitis can't be treated. Bacterial can, but bacterial is going to have the worst effects on the patient. Now, do know this though, meningitis doesn't just affect the brain. Meningitis affects meninges. So you have meninges in your spinal cord as well. So meningitis is typically more on the communicable disease aspect there. And again, viral or bacterial, bacterial is highly communicable. And any patient that you have that you suspect meningitis, you're not going to be able to tell is it viral or, bacterial. So you need to make sure you take precautions. Your common symptoms with meningitis, your textbook symptoms, photophobia, stiff neck, things like that. Of course, when we talk about spinal cord compression here, we're talking about more of non-traumatic spinal cord disorders. These are going to be, issues where you may have a slipped disc or degeneration of the cartilage around the disc. It may affect any of the structural part of the spine and cause a severe pain and inability to move and all that. And so again, with this, we want to make sure that we are treating symptoms and understanding that just because a patient has back pain does not mean that they need to be put on a backboard. Non-traumatic back pain and neck pain, that's one of the worst things that you can do for that patient, is put them on a backboard. Hydrocephalus. Hydrocephalus is seen really more in younger patients, and that's why you see right up under it ventricular shunt. Now, hydrocephalus is just overproduction of CSF in the brain, which causes a big head, watermelon head. Probably will make the parent mad if you call their kid a watermelon head, but kids are big-headed anyways. We're talking about even bigger than that. And the way that that's treated is through that ventricular shunt, where essentially they just put a drain tube in a ventricle in the brain, and it drains into the abdomen. If you read in the pediatric chapter, you read that there can be issues with those shunts, and oftentimes there can be acute issues that even, years after they have the shunt put in, start seeing, altered mental status, deterioration of mental status, things like that. So a quick review of neuro. Now we're going to move on into endocrine stuff. Any questions on neuro?